Good evening, everybody. Let's see, I'm Andreas Klein from Tufts Medical Center in Boston. Welcome to our fourth installment of the online Bone Marrow Transplant Journal Club. The goal of these events is to present and discuss recent publications and hear expert commentary and perspectives from the authors themselves. The format is meant to be informal, so I invite everybody to join in. We have a simultaneous Twitter feed, hashtag BMTOJC. If you want to follow along, there'll be slides being projected and sent out on Twitter. Tonight, on behalf of my colleagues Miguel Perales and Bill Wood, I'd like to welcome Mohammed Sorer as our discussant. Dr. Sorer is an associate member of the Fred Hutchinson Cancer Research Center in Seattle. He conducts multi-center clinical studies aimed at developing tools and information to guide choices of therapy in vulnerable patients with blood cancer and to better evaluate the usefulness of different treatment approaches, including hematopoietic stem cell transplant. In 2013, he was awarded a 4-year research scholar grant from the American Cancer Society, and the fund will funds a study to better define therapeutic choices for older patients with newly diagnosed acute myeloid leukemia. Our presenter this evening is Amol Asal. He is a first-year fellow at Memorial Sloan Kettering in New York. Amr did his HEMONC training in New York as well as Albert Einstein Montefiore. So, without further ado, Amr, why don't you go ahead?
Thank you very much, Dr. Klein, for the introduction. Yeah, we're here with this article by Dr. Sorer. We're very pleased to have him with us here, so we can ask him questions and interact with him. So this is the article. Basically, it's an article from 2015, and it has to do with the prospective validation of the HCT. Next slide, please. So, next slide, please.
Oh, sorry.
Oh, sorry.
Again, it's taking a moment.
Okay. Yeah, there's a little
there we go.
delay here. Okay. Basically, in oncology, as we all know, we often treat our patients with very toxic treatments, and then a very important thing for us to be able to understand and navigate is to see how much we can tolerate in terms of the side effects of treatment. And transplant, of course, takes a big toll on the body, whether it comes to conditioning or the duration of immune suppression. So the HCTCI was basically a tool that was developed to be able to capture the burden that certain medical comorbidities have on the patient who are being planned to undergo a stem cell transplant. And basically what it is able to achieve is that it's able to identify what the comorbidities are, and these are the ones that actually have an impact, and to come up with a scoring prognostic model where we can assess the risk of non-relapse mortality, and also to have an idea about survival in those cases. Next slide, please. So this is actually from the original paper, and here we see a comparison between the HCTCI and the TCI, which was a score that was available prior to the HCTCI. And here in a quick comparison, for example, A and B, we see that the HCTCI is better able to differentiate different risk groups based on the scores to come up with different risk groups of patients in terms of non-relapse mortality, and then in C and D, you see how it nicely stratifies patients in terms of survival. Next slide. There's a little slight delay, and here is actually an abstract that's hot off the press from ASH. Dr. Sorer presented his work on the AML, where the reason I put it in here is just to show that the HCTCI is not a finished story. The principal concept of identifying comorbid medical conditions and examining their impact on survival and outcomes can actually is still applicable, still a field of study, and in this case we see that similar system can be applied to acute myeloid leukemia. Next slide, please. And then in this slide here, I outlined two articles that were referenced in the article that we're presenting today. And the reason I put these in is to show, as in everything in science and medicine especially, there's usually controversy, and here there's two examples in the literature. There's many examples that support the HCTCI and confirm its findings, but here are two examples where there was evidence to the contrary. The first article is a Canadian article where they say that performance status was in fact more important, and the second article is evidence towards the limitation of the HCTCI. So there is still there is some controversy in the field, although there's definitely lots of evidence to support its use and its utility. Next slide, please. So the rationale for this study, basically the idea here was to actually, because the way the score was obtained initially was retrospective data, and the idea here was to come up with a prospective way to validate the score and to see and capture its power in terms of predicting non-relapse mortality and survival in transplant patients. Another utility of this current study is that it also extrapolates, well, not extrapolates, actually provides evidence of the HCTCI utility in autologous stem cell transplants, and the idea is, behind, if we are able to accomplish those goals, with this will allow us to have a tool that would allow us to better design bone marrow transplant trials and to standardize our understanding of patients in across centers, because then we can compare patients. We would be better informed about their outcomes if we can understand them in terms of their risk profiles. So the methods, this is CI-BMTR data. I believe a lot of the people in the audience are familiar with the CI-BMTR, but just a summary, it's basically well, it does a lot of things, but one of the things it does is collect data from participating centers, which covers huge geographic area, and they all feed data to the CI-BMTR, and that database is often queried, and a lot of analyses are published from it. One thing after 2000, after the original paper was published, the HCTCI was actually, so what the CI-BMTR does, it actually has forms where centers collect the data in these standardized forms, and then the HCTCI was incorporated into those forms in 2007, and they initiated a study to prospectively collect data and on patients, and the period was between 2007 and 2009. And the patients included in this analysis, in this study, were patients with hematologic malignancies, patients who received autologous or allogeneic transplants. Any conditioning was allowed, any conditioning intensity, by that we mean. And then they included HLA-matched related or unrelated donors, and they allowed grafts, whether they were from bone marrow or peripheral blood stem cells, mobilized with the growth factors. Next slide, please. And this is the organizational chart of the study, and basically here we see that how they arrived at the patients that were finally included in the study. So we have patients who received the first transplant, so second transplants were not allowed, almost 24,000. A little bit more than half was autologous, and a little bit less was allogeneic. And patients without consent were excluded, and insufficient follow-up, non-malignant diseases, and ultimately we arrive at 8,115 patients who received allogeneic transplants and 11,652 received autologous, and that's the group, the data of which contribute to this study. Next slide, please. So here are the study endpoints. So the primary endpoints we're looking at in this study was non-relapse mortality and overall survival. And here's some definitions that, again, are probably familiar to most of us in the transplant field, but the ones that I thought were most important to better understand this article. Basically, survivors were censored at the time of last contact. Conditioning was classified as high dose, reduced in density, and non-myeloablative. Comorbidities were actually collected from each site, and then the score was calculated centrally. And then this is an interesting thing. So, I mean, when they initially arrived at the HCTCI, they took into consideration the comorbidities that had a significant hazard ratio in terms of outcomes. And there's other comorbidities that were not included, but some people wrote them down and collected them. And what they wanted to see is that, is it still true that basically these other comorbidities do not have any common outcomes? And but they also wanted to make sure that none of these comorbidities recorded in the other actually should fit in somewhere else. So if they did a sample and they checked, and basically the score, if they were to reassign them manually, the score would have been changed in less than 5% of the patients. And then they also created this new group where if you had an HCTCI score of 0, but the other field had something in it, they try to examine those as a separate group to compare them to people who are truly 0, where there's nothing in terms of comorbidities on the forms. Next slide, please. And this is the statistics. So a paper like this often has very interesting, very powerful statistics to mine the data, and basically, I just wanted to put it here so people can see what they were. They did cumulative incidence and Kaplan-Meier curves to look at NRM and overall survival. This is competing risk idea, which since I've been doing transplant, I've learned about it. But basically, relapse or progression was treated as a competing risk. So basically, you can't like double count competing risk for non-relapse mortality and vice versa. And if there was a second transplant that was performed, the patient was censored. And then proportional hazard. This is typical statistics. They use hazard models to calculate the hazard ratio. And then they adjusted the models for patient-related risk factors, disease-related risk factors. So basically high risk or low risk AML, and then transplantation-related risk factors. And then they did multivariate analysis as well. Next slide, please. Oh, next slide, please.
Just a moment.
Coming. Thank you. Okay. So they looked at the HCTCI as a categorical variable, not a continuous variable, and then they basically looked at it stratified as score of 0, 1 and 2, and 3 or greater. But then they also did analysis looking at more stratification, so to speak, 0, 1, 2, 3, 4, 5. And they also did something to kind of see reports from different centers actually correlate with each other, and that is the kappa, the weighted kappa statistic. And they took samples from 3 centers, and then if it's closer to 1, that means there is concordance, and if it's lower than 1, that means, if it's close to 0, that means there's no concordance, it's random. Next slide, please. Yeah.
We're just at the mercy of Google. Of Mr. Google.
Great. So now we get to the exciting stuff, results, and basically this is table one. I try to squeeze it in here, but what I wanted to highlight is a couple of things here, which as any good clinician, always look at your table one and understand it, so you can understand the study better. And the things I wanted to highlight here were in the first part, in terms of age, we see that in the patients who are above 60, so like 6 line down or so, more of those received reduced intensity conditioning as opposed to high dose, which can tell us that the clinicians of those patients elected to give them reduced intensity conditioning. Another thing, and these could, are avenues for potential bias, and which is what every non-randomized trial has, or study has to address. Here we have also looking at the race of participants. This is again an American clinical trial thing. Majority of the participants were Caucasian. There's underrepresentation in terms of ethnic minorities. And then finally we'll look at the HCTCI score. So the second half of the table, and looking at a score of 0, we see that there was less people in that score. So there's patients with a score of 0 looks like were more likely to get myeloablative high-dose conditioning regimens. We see that only 41% were the ones who received reduced intensity or non-myeloablative conditioning regimens. So those are a few things that we can notice from this table. And then otherwise, everything else is outlined in terms of the different disease subtypes, graft source, CMV status, chemosensitivity of the lymphoma, etc. Next slide, please. And here we see the distribution of the comorbidities, and we see that the most common comorbidity that was noted here has to do with lung. And then the second most common was actually psychiatric comorbidities, and cardiac comorbidities came in third as well. And comorbidities were more common in patients who, which goes back to the initial table 1, what we noted, there was more comorbidities in patients who received reduced intensity conditioning. Next slide, please. Okay, so validation of the HCTCI. So again, this is prospective data, and let's see how the score assignments impacted outcomes. And in this table, this is all allogeneic transplants, relapse mortality and overall survival. We have hazard ratios and p-values. And looking at the top half of this table, we see that basically patients comparing to a score of 0. So one thing, notice that there's the 0 and then there's 0 but other comorbidity reported, and there's no significant differences there, which goes to support that the HCTCI actually captures what matters in terms of comorbidities. And we compare 0 to 1 and 2, and we see there is a significant difference noted in terms of the overall survival, and comparing basically the higher the score is, 0, 1 to 2, and 3, there's an increase in non-relapse mortality, and then there's a decrease in survival, and numbers were statistically significant. And when we look at them actually in terms of the further stratification, 0, 1, 2, 3, 4, 5, we see that the significance is maintained as a theme, but the 1 and 2 lose statistical power. So when they're combined, they do better, as opposed to when they're studied individually. So that's what we can see from this slide. Next slide, please. Okay, so here is another picture depiction of this, and we see that, so in this figure here, basically the figure A is comparing non-relapse mortality and overall survival in patients with allogeneic transplants, and we see the significance. This is ACTCI 1 and 2 and 3. There's two different groups in comparison to 1, and basically that little box does not cross the black line that's horizontal, which represents 1, which would mean that it's not significant. And we see the p-values there. But if you look at B, which has them 1, 2, 3, 4, 5, we see that the first two, 1 and 2, actually do cross that line, that little box, which suggests that it's not, the confidence interval crosses 1, which would mean it's not statistically significant. And B and C are basically 1, 2, 3, 4, 5 for non-relapse mortality and overall survival. So A is the same thing, but combines both into one figure. Next slide, please. And here is a curve distribution that shows how the HCTCI can actually separate the non-relapse mortality and overall survival by group and by score. And this is represented in a picture form. Next slide, please. Probability curve, sorry, which is a picture. Okay, so here, looking at this slide here, we're comparing myeloablative and reduced intensity, and I apologize, there's a little error here on the slide. Basically, A, C, and D are myeloablative, high dose, and B, E, and F are actually reduced intensity, and basically here what we see in the myeloablative, we have preservation of 1 and 2 is higher risk of non-relapse mortality, decreased survival, and 3 is even higher. But then it reduced, and then we see the depiction of those curves in the C and D, but then D being survival and C being non-relapse mortality. But then when we study reduced intensity as a separate group, the HCTCI score 1 to 2 loses its statistical power. We see the box crosses 1 there in panel B, and panel E and F is probability depictions, with E being non-relapse mortality and F being overall survival. Next slide, please. And this is from the appendix, but basically what we have here is looking at adults versus children, and we see here that basically we have non-relapse mortality and overall survival, NRM on the left and overall survival on the right, and ACTCI of 1 and 2 again loses its power in children, but 3 maintains its power, whereas in adults we see that it still is predictive of poor survival and increased non-relapse mortality. So there's 2 points here so far: reduced intensity in children. 1 and 2 is less gives you less increased risk. Next slide, please. Now we look at the data in terms of autologous transplants, and here this is the last half of the initial table that I showed. This is table 2 from the paper, and what we see on the just to orient the audience, what we see on the left is non-relapse mortality, and on the right is overall survival. And as you can see there, that HCTCI score of 1 and 2. It has a p-value of 0.2, which has less of an impact in terms of non-relapse mortality, but 3 is significant. The p-value is very small. Whereas in overall survival, we see that the HCTCI score of 1 and 2 gives you poorer survival than 0, and 3 even poorer survival than that. Next slide, please. And here is a probability curve depiction of the same idea. Next slide, please.
Still waiting for it to load, sorry.
No problem. Okay, and this slide here, basically in the autologous transplant, the most common indications for autologous transplant, lymphoma, multiple myeloma. They looked at those groups individually, and the same theme is there present in terms of non-relapse mortality and survival. Looking at survival, all the p-values are below 0.05, whereas looking at non-relapse mortality, which is the middle section of this curve, we see score 1 to 2, p-values 0.218 for lymphoma and 0.119 for myeloma. So similar to the overall autologous theme, when you look at lymphoma and myeloma subgroups individually, the that group 1 and 2 score loses its power to separate them into a separate risk group. But it is maintained in survival. Next slide, please. So the inter-evaluator agreement, so the three institutions they had sampled were Dana-Farber, Roswell Park, and Fred Hutch, and the weighted kappa statistic estimates were 0.54, 0.81, and 0.47, which, you know, fairly moderately fair concordance estimation. Not perfect, but pretty good. Next slide, please. Okay, so take-home points from this study. Again, this is from the paper. What this paper achieves is validates the ACTCI in a more recent patient sample. So the original paper was done in 2005, and the patients were transplanted even before. Enriched with patients with a HCTCI score of 0, they will have better outcomes. So having a standardized stratification tool help us understand studies that are reported and help us design studies much better. Next slide, please. And future direction, outstanding question. So this is basically just.
Oh, we lost them.
Are we back on?
I think you're back on. Oops.
Oh, okay.
Yep, you're back on.
Okay, great. So let me pick the slides. Okay, perfect. So this is really an exhaustive list of of all the questions that we can have. So, we can just to jumpstart the discussion, and also I think we're getting questions over Twitter, so we'll put them. So I'm just going to list them off, and then I'll leave the floor to Dr. Sor, who's with us here, to discuss. So a couple of things that came to mind that some are addressed in the articles, in this article itself. Basically, what else to do with the HCTCI, the future. We can combine it with biomarkers. So Dr. Sor's group has a another thought that I had was, what is the impact of post-transplant maintenance strategies? And obviously, the idea is that they improve outcomes, but the question remains: some of them have more toxicity than other, and the HCTC, sorry, we cannot really. Well, does it predict anything in that? Does it help select which patients should or should not be on maintenance because of increased toxicity? Another question about the HCTCI is the therapeutic range. So we see the numbers are there, and they show that there's power in discrimination in terms of score 0, 1 to 2, and 3. But what about patient with a score of 4 compared to a patient with a score of 9? Are they truly similar? The numbers suggest they are, but intuition suggests maybe they're not, but the numbers suggest they are. Finally, yes. So this is something that as an internist, is severe aortic regurgitation, which gets a score of 3, similar to someone with rheumatoid arthritis and depression, let's say. Again, the numbers suggest they are. Next slide, please. But then, as an internist, it's hard to reconcile that. And here, this is a table from the original paper, and I put it in here just to show the hazard ratios. And we see here, for example, heart valve disease, hazard ratio of 3.3, and then we look at psychiatric disturbance, hazard ratio of 1.8, and then rheumatologic is 2.3. So if you combine 2.3 and 1.8, they probably do it up to more than or similar to 3.3. And those are the numbers, and the numbers don't lie. But as an internist, is it still true that a severe aortic stenosis is similar to rheumatologic condition or any other combination thereof? Next slide, please.
Well, I guess while we're waiting for that slide to come up, Mohammed, why don't we kind of get started with you, and let's see, unmute your microphone. There you go. 1 second. Sorry, I'm just trying to get your microphone seems to be muted, and I can't quite unmute it on your side here. Come on. Unmute. Maybe if you could just shout really, really loudly. Sorry. Is it mute? Does it look like it's muted on your side?
It does, yeah.
It does.
Is there a button you can press on yours, like up at the top part of the screen?
No, it's
There we go. Perfect.
Can you hear me now?
Yes, I can.
Okay. I don't know how this happened. Okay.
All right. So let's. How about maybe we can start in terms of how much? So Emmer laid out a number of different factors that are pooled together to come to a composite score that seems to be quite powerful and potent in discriminating survival. And I guess the first, and we've seen it at ASH and at some other publications, some modifications to it, age-adjusted, other things. How important, how good do you feel the original score is, and how much better can it get, or should it get? Does it need to be better? Where do you sort of see the score going in the future?
So I think the study that was just presented, what we were trying to do is to validate that the model that was developed in a single institution here in Seattle, focusing on non-relapse mortality after allogeneic transplant, would perform similarly in a multi-center fashion in a prospective study, meaning that the increase in the scores would predict increased risks and hazard ratio for non-relapse mortality and overall mortality, which the study already has shown. And in particular, that there is almost a decade difference between the study, the patient that included in the original study and the patient that included in the validation study, about 10 years difference in their management. And that says that the impact of comorbidities kind of challenge the test of time. They continue to be important regardless of the development and supportive care, etc. There is always room for improvement because if you look at the original study, I don't remember the numbers on top of my head, but when we did the statistic estimates, whether for the continuous outcome or binary outcome, it was in the range of 0.65 or 0.67, meaning there is, if you compare it from 0.5 to 1, there is still room if you want to improve the performance of the model. And we have done different studies. We found that the best way to improve the model is try to augment it with other variables that were not tested originally. That's what we've done when we included the low albumin, the high ferritin. Low albumin as an indication of nutritional status, high ferritin inflammatory status or iron overload, and the low platelet count gives you an idea about the intensity of prior treatment probably, or maybe the disease. We also added age, 40 years or above, to the model. We also had another study where we showed that we can composite a model between comorbidities and performance status. So I think adding all these variables collectively increase our ability to stratify patient risks. And I think where the future is going is we're testing the study that Andreas mentioned earlier that got the American Cancer Society funding. It's mutually funded by the PCORI, Patient Centered Outcome Research Institution, and we're looking at so many other patient-related risk factors like frailty, geriatric syndromes, quality of life, and we also in other studies looking at molecular biomarkers. And I presented a study at ASH in the allogenic transplant session about the pre-transplant expression of microRNAs, those small non-coding RNAs that control gene expression. We found that 7 of those microRNAs actually can predict mortality and be linked to comorbidities. So there is a room of expanding the tool by adding more clinical variables, but also there might be a chance of adding molecular markers and other biomarkers that increase the objectivity of the model and increase the predictive power. I don't know if I answered your question or if you had something else in mind.
Yeah, so are there some of these markers which are actionable where you think we may be able to address them pre-transplant and improve outcomes?
Yes. I think that's where we're all going is to understand what exactly the impact of these comorbidities, how they impact outcome. We did a study, we found that, well, they predict the onset of graft versus host disease. They predict that patients develop graft versus host disease. Some of these microRNAs that we found, they actually predictive or control tissue inflammation and tissue repair, which gives an idea that the question that was raised, a patient with severe aortic regurgitation might have an ongoing microRNA expression that predict some kind of tissue damage, that a patient with rheumatologic disease or a depression might have the same thing. And then you have our patient developing graft-versus-host disease or sepsis or other complication of the transplant. So we are thinking and preparing multiple ways to intervene, and you can intervene in different ways. One of them is to target specific comorbidities and try to work closely with our colleagues, whether in the cardiac department or pulmonary department, how to better evaluate, better assess, and better manage patients with high-risk comorbidities. So that's one approach. The other is try to improve the collective performance of patients, things such as weight reduction and exercise. Instead of giving it to all patients, it's focused to the high-risk patients who have the obesity, the diabetes, the cardiac complication, where we can improve their performance, and that might improve their outcome. The laboratory biomarkers kind of open the door for future translation research, where you can work on an animal model and try to see if you can somehow change the expression of these markers, and that might reduce the chances of developing that kind of inflammation after transplant that will lead to something like graft-versus-host disease or infection, etc.
Okay. What do you make of the you're finding that in a number of these clinical situations, it seems that there's some amount of comorbidity that is trivial, or it just doesn't weigh in. What do you think at the sort of the low end of the scale?
Are you asking about the ones that made it to the model or the ones that did not make it?
No, I think the ones that do make it in the model, but yet, so there are patients who have scores of 0, of 1, and 2, right, which really doesn't seem to impact their outcome, or is it just that we don't have enough, enough numbers, we don't have quite the power to see?
No, I think that was intended. That's what we intended from the model, and we actually proved it worked as we wanted. Because when we developed the model originally, we included all patients. And in transplant, different from maybe other settings where comorbidities had been tested, we have the myeloablative high-dose conditioning, and we have the reduced intensity non-myeloablative conditioning. And you would expect that patients will tolerate the reduced intensity conditioning better than the myeloablative. And that's what the comorbidity is doing. It's showing you that if you give a patient high-dose conditioning only, and then autologous transplant, so no donor graft, or if you give them donor graft but with reduced intensity regimen, then patient will score up to 2, would do exactly the same like patient with no comorbidities. They can't tolerate the transplant similarly. But if you combine high-dose conditioning with donor graft, clearly patient with a score of 1 or 2 would do worse than score 0. And that's pretty important when you want to compare within a specific comorbidity group. When you take patients score 1 to 2 and say, well, if patient will score 1 to 2, all of them AML first complete remission, no minimal residual disease, borderline age 55 or 50, what would you prefer? Well, I would prefer reduced intensity regimen, because I can see that with the myeloablative regimen there is a higher risk of non-relapse mortality. So it makes sense to assign patients in a prospective study or assign them in a clinic to the one that you have shown that they can't tolerate the transplant, similar to patient with no comorbidities. So that's what was intended in the model, and we actually pleased that it came out in the validation study exactly like what we expected, that the prediction of mortality changes based on the amount of treatment that's been delivered to the patient.
At the on the last day of ASH, in the late-breaking abstracts, the results of the BMT 0901 study, the Maverick study, were discussed, demonstrating that in the for AML, in the AML group, where patients were randomized to either reduced intensity conditioning or full ablation conditioning, the mortality risk, the non-relapse mortality risk, was 3 or 4-fold higher in the intensive group. Yet the overall survival was still better. How do we sort of reconcile that when we're thinking about using that the comorbidity score and deciding maybe that we were predicting a higher mortality, yet perhaps we'll have to accept a little bit higher mortality risk from the procedure itself. Yet, there may still be an outcome benefit to the greater intensity.
So that prospective study limited the inclusion to patients with comorbidity scores of 4 or less. And I think there's still a lot of room where if you wanna do sub-analysis and look at how the outcomes look like in patients with no comorbidities versus patients with any comorbidity score 1 or more, because there could be that the benefit that was seen overall, it kind of changes based on the amount of risk that these patients have at the time of transplant. I would expect that the patient with more comorbidities, they will get higher non-relapse mortality with the high-dose conditioning, and you have the relapse risks about the same, and that by itself might change the overall survival evaluation. And vice versa with patients with no comorbidities, they probably, as we've seen in many retrospective studies and prospective studies, that in patients with score 0, they will tolerate the high-dose intensive conditioning similar to reduced intensity, and non-relapse mortality is extremely low, 2% or so, which would make the benefit of high-dose conditioning quite evident in preventing relapse and make the survival even more evident as better with high-dose conditioning. So I think there is a room to investigate further the benefit of each conditioning intensity based on comorbidities and also based on performance status as well.
Hemer, how about from you guys there in New York? You have 2 more questions?
Well, I mean, there's 2 more things maybe to bring up, and I mean they are addressed somehow in the. I mean, they are addressed in the literature. The one question is incorporating performance status in classical oncology, so to speak. Performance status is very, informative about how patients would do in response to different chemotherapeutic regimens. How does the performance status, kind of interact with PCI, or can it be actually a variable on the PCI? And there's 2 studies that kind of address that. So that would be a question for Dr. Sor. And the other question is about race and ethnicity. And I reference a study there that showed that, transplant race from, economically disadvantaged, belonging to an economically disadvantaged minority, African American or Hispanic, gives you worse outcome. But when you adjust for different variables then the impact of ethnicity does not last. So, like variables such as disease risk or donor source, and etc. But there's a lot of talk in medicine these days that patients with poor socioeconomic status, for example, have poorer access to very expensive medicines, and then that can impact their outcomes. So those are the 2 questions: performance status and impact of race and ethnicity.
So performance status, we've done a study in 2000, published in Cancer in 2008, that showed that in a multivariate model, the HTTCI and a Karnofsky performance status, each one of them has independent impact on non-relapse mortality and overall survival, suggesting that each of these tools capture a different form of health limitation. One capture organ dysfunction, and the other one capture physical performance and physical limitation. So, and at the end of that study, we created 4 risk groups where we split the comorbidities into 2 risk groups, split performance status, 2 risk group, and then combine them together to create a combined comorbidity performance status model. And we showed that it improves the stratification of survival. There are other colleagues that show other forms of capturing physical health, something what's called the instrumental activities of daily living, which is more precise than performance status, also can be combined with comorbidities to improve the stratification of outcome. And that's the advantage of building a model like the HCTCI. It's really focused on one item of health limitation, which is organ dysfunction. And it can be easily combined with many other parameters that capture health limitation, as physical health. Social health is something else that we're looking at. and there's, as I said, always room to add these factors. But what we tell physicians in the clinic is, when you see a patient, the patient should be, for transplant, should be evaluated for comorbidities and should also be evaluated by performance status, because there is an additive effect. A patient who's poor on comorbidities and poor on performance status is worse than a patient who is poor on only one of them in regards to outcomes. And that makes a big difference in how to assign patient for transplant versus non-transplant therapy, or based on condition intensity. In regards to race and ethnicity, I don't think we can add them to the model, but I think there is a lot of room to investigate. We know that there is an impact of race, and there might be impact of ethnicity on the outcome. And the question becomes, how much comorbidities play a role in that impact? Because it could be that the reason that some minorities are doing poorly in outcome, one of the reasons could be, especially that most of the studies that looked at race and ethnicity in transplant did not really adjust for comorbidities in their models. It could be that some of those minority patients, actually what they are suffering from is a higher burden of comorbidities compared to other race or ethnicity groups, and that might explain to some extent why they are doing poorly. So they have low access to care, but also they have a big burden of medical problems that increase their chances of mortality after transplant. So I think that needs to be investigated in the future.
Dr. Sor, how do you guys use the HCTCI there? Like, is there a particular cutoff that you would automatically say that you wouldn't transplant someone above, or that you would choose between different intensity regimens?
That's a very good question. Dr. Elaho Este. We wrote a paper, I presented a talk at ASH of 2014. We wrote a paper where we tried to explain to physicians how to use a comorbidity index in deciding between transplant versus non-transplant therapy in patients with acute myeloid leukemia, for example, whether in remission or in relapse. And we in our table at the end of the study, we said that we prefer transplant if there is at least 10% advantage in disease-free survival over non-transplant therapy. And how we do that is by looking, for example, in AML, you look at the different cytogenetic risk factors, or risk model from favorable, intermediate 1, intermediate 2, and unfavorable, and that will give you an idea about the relapse risk after transplant versus non-transplant therapy. And then you look at the comorbidities and performance status, and what kind of non-relapse mortality you would expect with each of these risk groups. And the general idea is, the higher the risk for relapse by cytogenetics, for example, the higher the comorbidity score that you would allow the patient for transplant with. Meaning, if you have a patient with a favorable AML, for example, and this patient, the chances of relapse with non-transplant therapy is relatively low, and when compared to transplant, the advantage of transplant is not clear-cut. Then you would only allow an older patient, for example, for transplant if the highest comorbidity score is like 2. Because if you go further beyond 2, then the non-relapse mortality will be so high and will cancel any benefit of transplant. But for example, if a patient has unfavorable cytogenetics, we allow patient up to a score 8 or more, and that would give the patient 2-year survival of about 20%. But those 20% at 2 years is better than 0% with non-transplant therapy. So it's really a very dynamic way in using the model, and it's really based on the risks of relapse.
Dr. Sor, just kind of building on the last question, one of the things that seems to come up in the clinic, when you have 2 patients, let's say, that have comorbidity indices of 4, one of them is a patient who had prostate cancer previously, currently NED, maybe might be on an anxiolytic, he gets a score of 4, versus a person who has a pulmonary function test where he's high risk at 3, and then maybe gets an 8 point with the cardiac risk. How do you reconcile those 2 patients? They have 4s, both of them, but they're physiologically different.
Yes, so when we make the decision about transplant versus non-transplant or about condition intensity. It's really based on what the model was built for. It's the weights or the scores rather than the individual comorbidities. Because that's the whole idea, is at the end you have a weighting system that give you a calculation of the risks based on the combination of factors. Some of them are numbers of comorbidities and some of them are burden of comorbidities. The different presentation of comorbidities, as I was saying earlier, we still investigating the biology behind why comorbidities lead to higher mortality. And there could be different reasons. One of them, as I said, creating a state of inflammation that increases the risks of developing some transplant-related morbidities. Others could be limitation in delivering the full care to the patient. So a patient with higher comorbidity score, for example, because burdened with so many other medical problems, might not be able to receive the full post-grafting immunosuppressive medications, full dosing, whatever. So what we don't look at the individual comorbidities when we decide, we look at the total score in deciding how to assign patients to different types of regimens.
Thank you.
Could you maybe touch just a bit on patient-reported outcomes and how you're integrating that into your scoring?
Yes, so the study that we're doing now, it's a large study where we are taking patients with AML from time of diagnosis. We collect data on patient-reported outcomes. We collect data on frailty, social support, social activity, satisfaction with care, quality of life, physical, emotional, etc. We collect a large amount of tools on patient-reported outcome. We capture performance status and comorbidities, and we'll try to see how these factors affect in the decision to proceed with transplant versus not, and on the final outcome, whether the patient receive a transplant or non-transplant therapy. So these studies are still accruing patient, and I think for the results to mature, we still need another couple of years in order to get the final say about what other factor, what other patient-reported outcome to be added to comorbidities. In my clinic, when I see an older patient, I do these tests. I test patient for frailty and for walk test, etc., because it helps a lot to see a patient with or without comorbidities, but what is the limitation? What is the physical health limitation? How much that affect? And a couple of years ago, I allowed the patient for a transplant, and he was 79.5 years old, AML. Second CR, he was close to 80 years old, and this patient, he received his mini transplant in the outpatient clinic, never admitted, and he's still alive 2 years after transplant, because when we did that assessment, even though he had a comorbidity score of 3, but everything else about him indicated a very robust physical performance and physical health that told us that he can't tolerate a mini transplant, and that proved to be right. And at the same time, and in the same month, I saw a 65-year-old that was really not able, even he was in a wheelchair, he's not able to move, had multiple comorbidities, and we told him that non-transplant therapy is a better way for you. So I do apply these things now, even though we don't have really solid data yet, because there are so much supportive data in other settings about their impact. And I think once we have the final results of the current study, that would shed more light how to implement these patient-reported outcome in the decision making.
Excellent. Thank you so much. It's almost 9 o'clock. Is there anything more there from New York?
I think we're good for New York. Thank you.
Or from UAB? Maybe? All right. Mohammed, thank you so much for spending the hour with us. We really appreciate that, and for your tolerance of the free connection through Google Hangouts. Someday we'll be able to afford the real deal. This won't be an issue.
Thank you very much.
Terrific. Thank you very much. And I want to thank Bill Wood, who's been tweeting diligently and on the sidelines. And thank you, Amber, for an excellent presentation. Really appreciate you, despite having been at ASH, doing all of the ASH things and still coming back to present. We really appreciate that. So let's see, we hope to bring you the next installment maybe by the very beginning of February, or if not that, at the beginning of March. And if you're attending ASBMT, Mohammed, are you coming to the meeting?
Yes, I'm coming.
please join us for an informal get-together. We'll send an invitation both to our fellows listening and to our faculty to come and to meet everybody face-to-face in Honolulu. It's almost embarrassing to say it, but it's a great meeting. So, terrific. Thank you so much. Good night, everybody.
Good night.